Good afternoon, everyone. Welcome back to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. We're back to virtual only this week, largely because we have an outside speaker. We'll come back to hybrid next week. So those of you that can make it, please join us in HSW 300, although we will be hybrid as well, probably forevermore. You saw the ground rules on the previous slide. If you have questions, just type them in the Q&A box. We'll try to get to some of yours as well as mine. And if you're interested in seeing me, stay on till the end, and there'll be a slide there showing you how to do it. We're now doing COVID sessions monthly, and it feels like an appropriate time to do it. We're back in something of a surge, although it has a different feeling than prior surges, in part because behavior and policy has changed, and in part because we have some new variants that are affecting the surge. I think a lot of us know friends and family and colleagues that have COVID. Luckily, we're not seeing a large increase in hospitalizations, although we're seeing some at UCSF. We're up to about 25 COVID patients in the house, up from about 10 to 15 2 weeks ago. So it's affecting us. There are some severe cases, although not nearly the severity that we had earlier. We have a lot of effective tools that we didn't have at the beginning, including vaccines and boosters and a variety of outpatient and oral therapies, but they're all challenged by changing science, significant uncertainties, and of course, misinformation. So there's a lot of stuff to untangle, and that's what we're going to do in the next hour. We'll divide our time into two segments. The first, we'll talk about vaccines and boosters. The second, we'll talk about antivirals and other treatments for outpatients with COVID. We have three wonderful speakers to help educate us on those topics. For vaccines and boosters, I'm thrilled to have our old friend Paul Offit return to Grand Rounds. Paul is professor of vaccinology at Penn and professor of pediatrics at the Children's Hospital of Philadelphia, where he directs the Vaccine Education Center. He's been a member of the Advisory Committee on Immunization Practices at the CDC. He's a member of the Institute of Medicine or the National Academy of Medicine, and co-editor of the foremost text in vaccinology called, appropriately, Vaccines. So Paul, welcome. Thanks for joining us today. Paul will be our sole guest for the first half. And in the second half, we'll have two guests. One is Sarah Doernberg, who's Associate Professor of Medicine in our ID division at UCSF Health. She's also the Medical Director of the Adult Antimicrobial Stewardship program at UCSF Health System. She has an active outpatient ID clinic and sees inpatients in the transplant ID service and does research in all of that. So Sarah, welcome. And the second guest also from our family here is Annie Luetkemeyer, who is Professor of Medicine in the Division of HIV, Infectious Diseases, and Global Medicine, based at Zuckerberg San Francisco General Hospital. She leads clinical trials on novel therapeutics and prevention strategies for COVID, including antivirals, anti-inflammatories, and vaccinations. Annie co-chairs the UCSF Interventional COVID Clinical Trials Committee. She's the site principal investigator for the UCSF Coronavirus Prevention Network. And Annie, welcome aboard. Thanks for joining us. And so Sarah and Annie are just going to listen for the first half hour, and we'll turn to Paul. I think Paul's going to start off with a short soliloquy, and then we will get to Q&A for the last half of his segment. So Paul, welcome aboard.
Right. Thank you very much, Bob. I don't really think of it as a soliloquy as much as a rant, but I'm going to do this hopefully in fewer than 15 minutes. So I think the first question is what is the goal of this vaccine? The goal of COVID vaccines is to protect against serious illness, because that's the only reasonable goal. When you're vaccinated or naturally infected or both, you will develop neutralizing antibodies, which will be present for about 3 to 6 months before they will fade. And you will develop memory B cells, memory T helper cells, and memory cytotoxic T cells, which for the most part are long-lived. If you're trying to protect against serious illness, the good news is it takes a couple of weeks to develop serious illness, and that's plenty of time for activation and differentiation of those memory B and T cells to become effector cells. And so therefore, one can reasonably expect that you would be protected against serious illness for a fairly long period of time, a year, 2 years, 3 years, or longer. However, in terms of protection against mild illness, that's because these incubation periods are relatively short, like influenza or like rotavirus. The SARS-CoV-2 has an incubation period of 4 to 6 days, especially even shorter with some of these more recent strains. That's not enough time for activation and differentiation of those memory cells to protect you against mild disease. To be protected against mild disease, you really need fairly high levels of neutralizing antibodies at the time of exposure. And the only way to achieve that is with fairly frequent booster dosing, which I think is not a viable healthcare strategy. So I think we need to make that clearer. And I think probably the worst communications error that we made with this vaccine was ever using the term breakthrough to describe a mild illness. I mean, that is a vaccine that's working well. The goal is to prevent severe illness. The rotavirus vaccine, which I was fortunate enough to be part of a team at Children's Hospital Philadelphia that created the strains that became Rotatek. Rotavirus vaccines keeps babies out of the hospital and keeps them out of the ICU, but the virus still circulates in the community and still causes mild illness. So I think we need to define what we want from these vaccines. And in order to do that, I think the word booster is confusing. I think we need to define clearly for whom this is a 2 or 3 or 4 dose vaccine to develop adequate frequencies of memory B and T cells to protect you against serious disease. And for that, you need clear evidence from the CDC as to what backs up those recommendations for a 2 or 3 or 4 dose vaccine. The term booster, I just think, is confusing because what are you boosting? I mean, for the most part, what you're boosting is neutralizing antibodies, which you'll do for about 3 to 6 months, sometimes a little longer, but that's what you're really boosting. Memory is not so easily boosted, is the truth. So I think in terms of our committee, the FDA Vaccine Advisory Committee, is going to, at the end of June, consider strains to pick strains for what will be, in theory, a fall vaccine. I'm a little confused by the goal there. We get a yearly flu vaccine because even if you've been naturally infected or immunized the year before, you may well not be protected against serious illness caused by flu. That doesn't seem to be true for this coronavirus. I mean, for the most part, protection against serious illness does appear to be holding up, especially for sort of healthy people less than 50 years of age. So I'm not sure what the goal is there. The other thing regarding variant-specific vaccines, if a variant arises that is resistant to protection against serious illness induced by vaccination, then you need a variant-specific vaccine. I think right now, if you look, for example, this push for an Omicron-specific vaccines, look at the non-human primate data, or even the human data, the human primate data. What you find is that if you've gotten 3 doses of a vaccine with this ancestral strain, right, all the vaccines that are made, Pfizer, Moderna, J&J, AstraZeneca, are all made to protect against this ancestral strain, the original strain that raised its head in Wuhan. If you look at the immune response against Omicron after 3 doses of the ancestral strain vaccine and compare it with 2 doses of the ancestral strain vaccine, with the 3rd dose being Omicron, there's really no difference. I mean, there's a broadening of the immune response with that 3rd dose against Omicron to protect you against this immune evasive strain. And I think that's really the difference here. When this virus raised its head in Wuhan, the Wuhan, so-called Wuhan/2020 strain, that's not the virus that left China. The virus that left China was the D614G variant because it was more contagious. Swept across Asia, swept across Europe, swept across the United States, killed 200,000 people here, which was replaced by the Alpha variant because it was more contagious, which was replaced by the Delta variant because it was more contagious, which was replaced by the Omicron variant and now the BA2 variant, not because they're more contagious as much as they are more immune evasive, because this is something I think that surprised virologists. This is a drifted virus. I mean, it's more like flu in that sense, that it has drifted. There's 15 mutations in the receptor binding domain and 30 mutations in all in the SARS-CoV-2 spike protein. So I think that is a drifted virus. But the good news is you still appear to be protected against serious illness. So you're not as well protected against mild illness. And that's what you're seeing now in the community. In Philadelphia, for example, we recently had a surge in cases. And so our health commissioner sort of got nervous. And so she said, let's just reinstitute the indoor mask mandate again. I think we were the first city in the country to do that again. But what didn't happen is there wasn't a consequent increase in hospitalizations. There wasn't a consequent increase in deaths because mostly you were just seeing mild disease in people who were already, for the most part, protected, because at this point, we're probably at least 90% population immunity with regard to natural infection or immunization or both. The problem with that 90% is it's not equally distributed throughout the country. But I think that's why you're seeing, where you see cases, you don't necessarily see that being followed by a dramatic increase in hospitalizations and deaths, because for most part, the people that are getting mild infection are protected against serious disease from being vaccinated or naturally infected or both. With regard to the 5 to 11-year-old, when our committee met on October 26th to discuss the vaccine for the 5 to 11-year-old, Pfizer presented roughly a 2,300 child study. 2-to-1 vaccine to placebo is roughly 1,500 vaccinated children in that age group and about 750 who received placebo. There were 19 cases of disease, all mild disease in that trial. 16 were in the placebo group, 3 were in the vaccine group for an efficacy of 91%. Then the vaccine was then distributed beginning in November into children in this country. There's about 30%, 25 to 30% of children 5 to 11 years of age have been immunized. It's about 10 million children. Then what you found, according to most recent New York State data, is protection against mild disease was not nearly as good as those data that we were looking at the end of October. And the reason is that when the study was done by Pfizer, that was submitted to the FDA for approval through emergency use authorization, that was done when Delta was predominant. When the vaccine was then released at the beginning of November, then Omicron became predominant, which is why then efficacy against mild disease lessened. However, at least according to most recent CDC data, protection against serious disease is still holding up in that age group, which is what you would expect. And I think that this is going to be the same issue that we're going to be dealing now with the less than 6-year-old. You've probably seen the press release data from Moderna. But for that 6,700 child study, a 1-to-1 vaccine to placebo, what they found was that there was like 51% efficacy for the 6-month-old to less than 2-year-old. There was 37% efficacy for the 2-year-old to 6-year-old, which is what you'd expect, because it's the ancestral strain vaccine and you're trying to protect against Omicron, and it's not going to be that good against a mild illness. It'll be interesting to see how our committee views this, because we will be reviewing these data in June. My understanding is in June, we are going to be reviewing Novavax's vaccine, their purified protein adjuvanted vaccine. We're going to be reviewing the vaccine for the less than 6-year-old, and we're going to be thinking about picking strains then for what will be, in theory, a fall vaccine. But I think it'll be interesting to see how we consider these less than 6-year-old data when you would have to imagine that those children would be protected against serious illness. But again, to do the kind of study to show that a young child is protected against serious illness, you would need to do hundreds of thousands of children in a study, which obviously we're not going to do. So this is just something that would have to be determined post-approval. So that's my rant. I guess if there's any take-home message here, I really think we are going to have to get used to mild illness, because mild illness has to be part of this virus going forward. This virus is going to be circulating for decades, I think, in this world, and mild illness will be part of that, which is true of every other mucosal vaccine. I mean, recently there was an ACIP meeting where one of the voting members actually said that they want a better vaccine against mild disease. If you want a better vaccine against mild disease, you're going to have to lengthen the incubation period, and that's not going to happen. So I think we're going to have to get off this zero tolerance strategy that we have at this point, because right now anybody who has a mild illness is treated in a manner that I think is going to be hard to maintain in the years ahead. Thank you. I am done with my rant.
Thank you. That was halfway between rant and soliloquy. I think not completely rant. All right. Let me start out by playing devil's advocate, an argument I'm sure you've heard before. When I hear it wasn't designed to prevent all illness, mild illness, or symptomatic infection, there's a sort of instinctive response, which is, I don't care what it was designed for. It used to do that. It doesn't do that anymore. A booster helps it do that again. I don't want to get COVID if I can avoid it, both because I don't want to get sick for a week and miss out on what that implies. I don't want to infect other people. I don't want to potentially get long COVID, which seems to be a very real thing. Emerging data says that your 1-year outcomes or long-term outcomes after COVID may be worse in terms of non-infectious complications like MI and diabetes. So there are a lot of reasons that if at no cost and essentially zero risk, I can get myself better situated to avoid mild infection, why not? So what's the response to that? Why not?
Okay, well, first of all, when the data were presented back in December of 2020 for Pfizer and Moderna's vaccine, those vaccines were 95% effective against mild illness. They were. And I think that created an unrealistic expectation. They were 95% effective against mild illness because those studies were done over a period of 3 months. Therefore, all the participants had recently received their second dose. Therefore, they all had high neutralizing antibody titers. If you look 6 months later in study after study after study in this country, you found that protection against serious illness was still in the sort of 85 to 90+% range. But protection against all symptomatic illness, including mild disease, clearly dropped down to 70%, 50%, which is exactly what you would have expected. I think the two communication errors we made were, one, at the beginning, we should have made it very clear that protection against mild illness was not going to hold up over the long run, because it doesn't for this kind of virus. And secondly, when that then occurred, we saw it happening in July, August of 2021, we should have never used the term breakthrough. But okay, so your argument is I don't want any kind of illness. I don't want to even suffer a mild or moderate illness. Therefore, I am willing to get a booster pretty much every 6 months. I just don't see that as a viable public health strategy. We do that for no other mucosal virus, and frankly, it won't happen. I think that we're already a little bit at booster fatigue now. Look at the percentage of people who are recommended to get, and say, I don't really actually like the term booster. I prefer for some people to get adequate high frequencies of memory B and T cells. They need 3 doses. For some people, they need 4 doses based on age or comorbidity or both. And I think we need to more clearly define that, because terms like second booster, first booster, second booster are confusing. I mean, I'm confused, and I'm on the FDA's Vaccine Advisory Committee. I shouldn't be this confused. I think I think if you ask Americans, what does it mean to be fully vaccinated? I think you get a lot of different answers.
Well, one of the tensions here, Paul, I think is the question: what is the right public health strategy, and the sort of a viable strategy that people will do it and it will work, and versus what is an individual strategy that people should have the option to take. And in that way, I guess I'm still trying to figure out. I get that people are not going to be willing to go in for a vaccine or a booster, whatever we call it, every 2 or 3 months. But at an individual level, for someone to say, I still would prefer not to get this thing, and it seems like it's pretty much risk-free and cost-free, so I'm willing to go in every 3 months to get a shot. What's the argument against that as an individual medical care strategy versus the whole public health issue, which I understand?
Right. Well, first of all, nothing's risk-free. Anything in medicine that has a positive effect can have a negative effect, and that's true of these vaccines as well. And I think we have, certainly for, say, the 16 to 39-year-old, there is an increased risk of myocarditis. And we have, I think we've undersold the potential harm with myocarditis. I mean, you see now that in some of these follow-up studies, even 6 months later, you still have evidence of myocardial inflammation. And there have been 2 reported deaths from mRNA vaccines, both in the New England Journal of Medicine, and an additional 8 reported elsewhere. It's not completely benign. And more recently, the data that were presented at the ACIP for the over 40-year-old was pericarditis is a risk of these mRNA vaccines. I mean, you already know about the risks of clotting, including serious clotting with the J&J vaccine. Nothing's risk-free. And I'm with you that if the benefits are absolutely clear, then sure, get the vaccine. But there is always a risk. And I just think we have been great at explaining that risk. Regarding long COVID, because I think really this drives this in many ways, that you can get long COVID even with a mild disease. Therefore, I don't want to get a mild disease. Therefore, I'm going to get frequent boosters. I do think we need to define long COVID better. If you look at these meta-analyses recently with long COVID, the single most common side effect or symptom is fatigue. And I just think we need to be much more objective about defining long COVID. If you've been vaccinated, if you've been what we've currently defined as fully vaccinated, what are your chances of getting long COVID? Who are the people who get long COVID? There's recently a Cell paper that went through sort of what the characteristics are of people who are more likely to get long COVID. But I think long COVID is more than one thing. And I think we need to define it better. If we're going to use that to drive this sort of frequent boosting strategy, I think we clearly need to find who's at risk.
Yeah, because it is actually what drives it. And me personally, I feel like I'm not worried about dying from COVID anymore. I still would prefer not to get COVID if I can avoid it because of the long COVID risks, which I agree are somewhat uncertain, and the long-term risk for non-infectious complications are a little bit up in the air, but at least seem real. Let's talk about the kids for a second. So I mean, there's a lot of parents out there very concerned about their kids. You're a pediatrician, you take care of these kids and their parents. They wonder like why it's taken so long. Is there something wrong with the FDA process or with the companies? Or what's your take on why it's taken so long to get to the 1 through 5 year olds?
Well, we worked our way down. I think correctly, we worked our way down. You know, if you look, 80% of the deaths have occurred in people over 65 years of age. 93% of the deaths have occurred in people over 55 years of age. And this is a fatal disease primarily of older people. That said, I mean, we clearly, when we reviewed the data for the 5 to 11-year-old, of whom there are 28 million children in this country at the end of October, at that point, had been 8,300 hospitalizations, there had been 62 deaths. And obviously with Omicron, there were far more hospitalizations then. And then children made up about 10% of the cases that were coming into the hospital at that point. So children certainly can be hospitalized, they certainly can die, and we do need to protect them. But I think we worked our way down. And it's always easy. First of all, I mean, you know, I guess I'm coming this as a perspective. We created the strains that became the bovine human reassorted rotavirus vaccine. That was a 26-year effort. I mean, these things are happening remarkably quickly. And remember, you really have to do phase 1 studies when you get to younger age groups. When you had the 12 to 15-year-old, that for Pfizer, that was still a 30 microgram dose. So there was a lot of experience with that dose and that dosing interval. When you get to younger children, we sort of do arbitrarily group them, the 5 to 11-year-old or the 6-month-old to less than 6-year-old. Those aren't all the same. And you saw that with the efficacy data for the less than 6-year-old, where it was clearly more effective in the 1 to 2-year-old than it was in, say, the 3, 4, or 5-year-old. And so you need to really do phase 1 studies, which take time, where you try and get the right dose, the right dosing interval, and the right number of doses. I mean, look, you know, Moderna has submitted for the less than 6-year-old as a 2-dose vaccine. Pfizer is in the midst of a 3-dose trial for the same age group. So not so easy. And I think we've worked our way down. I think actually it's happening remarkably quickly in the scheme of this. This virus was identified and sequenced in January of 2020. We had finished 2 large clinical trials within 11 months. I mean, that is the fastest vaccine ever made. The previous winner of fastest vaccine ever made was the mumps vaccine, which was a 4-year vaccine. And that's from isolation of the virus to having a commercial product. And that was a different time. I mean, the regulatory burdens were far less then than they are now.
Sort of a blockbuster study that came out of the CDC a week or two ago that said that 60% of everybody has had COVID and 75% of the kids have had COVID. How does that change your thinking about vaccines, given what we know about hybrid immunity? And if you've had COVID, the impact of a vaccine might be somewhat different.
Right. I think the most surprising data that were presented to us, and this was the end of October, this was many months ago, was that at that point, for the 5 to 11-year-old, 40% were seropositive, which tells you that there's a lot of asymptomatic infection out there. But see, when you get a vaccine, you're getting essentially a known dose, if you will, of SARS-CoV-2 spike protein that you're going to make. I mean, it's pretty uniform. When you're naturally infected, it's variable. So it does appear that in terms of generation of not only neutralizing antibodies, but frequencies of memory cells, that there's a difference between, say, an asymptomatic infection and a mild to moderately symptomatic infection in terms of what you're getting. So it's a little more variable when you're naturally infected in terms of protection. Obviously, you find studies both ways. You can find studies that show it's better to be naturally infected, others that show it's better to be vaccinated, and that's all because of the variability associated with the viral burden that you're naturally infected with.
But it sounds like not much ambiguity that it's better you're better off with both. If you are naturally infected, you should get vaccinated.
Yes, you said it, hybrid immunity. That's absolutely right. Those are the winners. But, you know, obviously, I mean, natural infection is fine as long as you live.
Yeah, good point. One more question on the little kids. I know a lot of parents are concerned you're going to have a role in the approvals. Maybe you can't talk about this, but what would you say the odds are that there will be vaccines for little kids under 5 by, let's say, June or July?
Yeah, you're right. We're specifically told not to comment on anything that we're about to review.
Nobody's watching this. You can just tell me, Paul. It'll be okay.
Okay, as long as nobody. Okay, just if we can just keep it in mind. No,
exactly.
We will consider this in June. I think the frustration is that because occasionally I have to answer these kind of questions on TV occasionally, and it's just what I'm looking at and what you're looking at is the same thing, a press release. I mean, that's where we're at now. I mean,
Right.
when we review those data, we are going to get probably an 80 to 100 page submission from the company. We're going to get an additional 80 to 100 page submission from the FDA, where they look at all the data that were submitted by that company so that there's no omissions or worse, misrepresentations. And then you have all the data on safety, efficacy, and you can make a more informed choice. I mean, I can only say that the voting members of this committee would never vote to approve it unless we would give it to our own children. But again, children do not commonly suffer severe or fatal illness. So safety is always is paramount.
And a recent study came out the other day that said that I think 1 in 5 parents would give it to their kids if the FDA chooses to approve it. Is that a rational stance to say that you've said the kids don't get sick very often or get very sick very often, that we know 3/4 of them probably have already have it, so have some measure of immunity? There's the issue of the pericarditis and myocarditis and all that stuff. If you approve it, do you think it's a rational stance on the part of parents to say maybe not?
I think, Maurice Hilleman, who is the father of modern vaccines, he did the primary research and development of 9 of the 14 vaccines that are currently out there. He said it best. He said, quote, "I never breathe a sigh of relief until the first 3 million doses are out there." So I do understand that thinking at some level. There are no risk-free choices, just choices to take different risks. And I think that the variability of natural infection in terms of its capacity to protect is one thing. The second thing is this virus is going to be with us for decades, and children grow up. We still vaccinate children with polio every year in this country. We haven't had a case of polio since the 70s. We do it because the virus still exists in the world. Frankly, I wish we would take all this sort of booster mania we have, send those boosts overseas and vaccinate those people. I think we'd be better off in the long run. But so you're right. I think these are all, we're building the plane while the plane is in the air. And I think we're learning as we go.
All right, let's switch to the adults. So booster number 2, shot number 4, whatever you want to call it. How do you weigh the risks and benefits for, let's say, somebody like you or me, assuming we're reasonably healthy, 60-ish-year-old people?
Thank you. I am a reasonably healthy, at least 60-ish-year-old person.
I understand.
What I would say is, so I actually haven't gotten a 4th dose. I mean, I think that the data on 3 doses for somebody who is otherwise healthy and over 65 make me feel comfortable that I am protected against serious illness. So I haven't gotten an additional dose. So see, for me, it's why the word booster is so hard. The question is, for whom is this a 3-dose vaccine, and for whom is it a 4-dose vaccine? It's a primary series to generate adequate, hopefully long-lived memory B and T cells. And I think that needs to be much more clearly defined. I really wish and we're all using, me too, use the word booster, but it's really, you don't really boost memory so well. I mean, John Murray has shown this, others have shown this. You get a little boost in memory cells, but not much. I mean, you're really boosting is neutralizing antibodies, which is a short-lived thing. And is that really which one? I just think if we need to make that clear to people, that what you're really boosting is your neutralizing antibodies, which will protect you for 3 to 6 months against largely mild illness. Just because I think people are confused by that.
Yeah. Would one of the questions from our listeners, would a mucosal secretory IgA-based vaccine achieve primary prevention? Would that be a better choice?
Yes, so in theory, and certainly people like Akiko Iwasaki at Yale are working on a nasal spray vaccine. And that was the same thinking behind FluMist, the nasal spray flu vaccine, is that you will induce memory IgA cells, for example, in the nasal associated lymphoid tissue, et cetera, and that then will lessen shedding, lessen contagiousness. It won't eliminate it. I just want to make it clear that you will still have mild illness and you will still have shedding, but you could have lesser shedding. The experience with FluMist was a little disappointing, but that doesn't mean that this couldn't be of value here. And I think we'll soon see what those data are.
And any reason to believe it would last longer? I mean, I think I have an image in my mind's eye that you're coating your nose and you're spraying yourself every morning. Obviously, that's not it. You're inducing a different kind of immunity.
Yeah, I would be pleasantly surprised if it lasted long. I mean, I worked on a mucosal vaccine, the rotavirus vaccine, and it's mild illness is still out there.
Yeah. What's the current thinking about mix and match for somebody's first booster or second booster, if you choose to do that?
No, I think we're learning about that. Whether if your initial vaccine is the mRNA vaccine and then you inoculate with the vector virus vaccines and vice versa. Now you have Novavax that's about to come online as a purified protein vaccine. I think we're going to be generating, but clearly there's evidence of sometimes better immunity with this sort of heterologous mixing and matching vaccines. Yeah.
So, I mean, for me, I got 3 Pfizers, and I did choose to get my 4th and got a Moderna. Is that so? For all else being equal access, you think that's a rational thing to do?
Sure.
Okay, good. Maybe last question. You've been in the business of combating misinformation for a lot of your career. Where do you think we stand on that, and how do you think we've made any progress in understanding it and dealing with it?
I think we were doing great right up until this pandemic. I mean, if you look, sort of the birth of the modern American anti-vaccine movement was in the early 80s, associated with this false notion that the wholesale pertussis vaccine caused permanent brain damage. And then it got an additional boost with, so to speak, with the false notion that MMR vaccine caused autism and Andrew Wakefield. And then it really faded. I mean, there were anti-vaccine representatives on ACIP or on VRBPAC. I mean, the Vaccine-Related Biological Product Approval Committee. I mean, Barbara Fisher is an anti-vaccine activist, was a voting member on VRBPAC. I mean, they were brought into the mainstream, and there was not a politics to it. I mean, if anything, with the outbreak in Southern California, which was sort of in a bohemian community, if people still use terms like bohemian community, I mean, that was, if anything, that was a left sort of leaning phenomenon. That is not true now. What's happened is the message, which was fading, of vaccines cause autism, diabetes, multiple sclerosis, attention deficit disorder, faded because it was wrong. And it was wrong, and it was wrong, and wrong. And so they no longer did they have the attention of mainstream media, and they sought, and now have social media. What happened here, though, is they have been embraced by the right, because the message, bodily autonomy, don't tell me what to do, libertarian notion, has resonance on the right. And you see these right-wing rallies, which embrace this sort of anti-vaccine notion, which has given them a lot of money, a lot more attention. And so it has swung wildly to the right that wasn't true before.
And is there anything that we can do to combat that? Are there lessons from what worked in the past, or is the world of social media and the world of partisanship so different that we're kind of stuck?
I think I don't think it's a knowledge deficit. I don't think that's. I think it's a trust deficit, and we just have to find, because that's at the heart of this. It's a complete lack of trust of the federal government, of the medical community, of the pharmaceutical industry. And I think that's it. The one hopeful thing, so I don't want to end on a completely down note, there's a woman named Dr. Ayla Stanford, who's an African-American surgeon at Temple, who just took it upon herself to create something called the Black COVID Coalition. So she goes into North Philadelphia, a marginalized, underserved community, and convinces 75,000 people to get vaccinated or get tested, because she provides something the healthcare system didn't provide, which was a physician to sit in your room and talk to you about this. And I think she was able to overcome that incredible amount of distrust. I think hopefully she's a model for the future.
Yeah, and we've had some of the same in San Francisco, with really wonderful partnership between the community and the Department of Public Health and our institution as well. And in some ways, in the early days, we thought the problem of anti-vax would be in the very left or in marginalized communities. It hasn't been. It's really been a very different kind of problem than we expected to confront. So. Great, thank you. Maybe one last question for you. So you haven't gotten booster number 2, shot number 4, whatever you're going to call it. What would induce you potentially to do that? Is there some height of surge that would say now it's time? Or, if it becomes a yearly thing and it's your numbers up, what would get you to want to do that?
I guess I would like to see clear data that someone who is over 65, who has no comorbidities, who despite being 3 doses developed serious illness, that there's clearly evidence. See, part of the problem is that there obviously there's 2 separate questions here. The question number 1 is, what percentage of people who are hospitalized are vaccinated? And question number 2 is, what percentage of people who are vaccinated are hospitalized? Those 2 separate questions. Ultimately, if 100% of the population was vaccinated, then 100% of the people who are in the hospital or hospitalized will have been vaccinated, because the vaccine is not 100% effective. So that's the question I want to see answered is of people who are say my age, given 3 doses, where's the evidence that there's a clear increase in their hospitalization?
Okay,
that would induce me to do it, but I haven't seen those things.
Okay, and this is how I'll segue to our next segment. Does the fact that there is Paxlovid or other effective antivirals, does that change your thinking about needing an extra shot?
It certainly makes me feel great. Dr. Califf, the current FDA commissioner, said it best recently on a podcast. He said, think about it. If you're vaccinated, you have a 90% chance of avoiding serious illness. And if you've gotten a mild illness and you want to avoid the progression of serious illness, take Paxlovid, you decrease your chance of serious illness by another 90%. So you can put those two things together. Very few people should die of this virus in this country. And I think that's true. So yeah, I think Paxlovid is a breakthrough.
All right. We should have warned the audience that there was that kind of higher level math coming at them. But, all right, Paul, thank you so much. We will find out whether that in fact is 90%. Let's bring on our next two guests. Thanks so much, Paul. All right, Andy, welcome. Sarah, welcome aboard. Why don't you first react to what you just heard? Any disputes with it or any changes in your thinking as you hear Paul, who knows more about this than anybody in the universe, discuss his feeling about vaccination? Andy, why don't you start?
Yeah, right. I think that the $1 million question here, and Paul, you alluded to this, is that probably COVID's coming for all of us, and at some point in time, it's certainly sticking with us for a long time. And what are we really trying to do with the vaccines? And the idea of never wanting to get COVID, I think for many of us is driven by two things. One, by all the inconvenience that it causes, and maybe life will change, but it's still, even if it's mild, is very inconvenient to have to not go to school, worry about loved ones who might get quite a lot sicker than you are. And then the whole thing about long COVID, which is different from influenza or from other infections that people get. And I think we're still in that place where it's hard to not want to get COVID at all costs if you can avoid it, both for the people in your lives who might get sicker, for the inconvenience, and for the long COVID piece. And I suspect we will sort that out. And I also suspect that he's right, that no matter what we do, we're not going to have the vaccine that we want that will be perfectly, protected. That's just not the nature of this virus. And that's hard because it looked that way to start with. And that's a big psychological adjustment to make.
Yeah. Sarah?
As long as you don't make me do the math,
It's complicated.
Paul was presenting, I'm okay. I will say, I think the medications are really great at decreasing the risk to people who do get infected. We don't know what the marginal benefit is for those who have been vaccinated. The trials were all done in unvaccinated individuals, so I don't know that we can throw numbers out. It's likely that there's some benefit. And then I will say, as we move towards talking about therapeutics, I would frame the discussion as, what are we trying to achieve with therapeutics? Similar to the discussion of what were we trying to achieve with vaccines. And I think there are four things that I think about. One is protection from really bad things personally happening, so death or hospitalization. Two is prevention of long COVID. There's minimal data about that, but something that we are interested in. Three is, will it make me feel better? Acutely. And then four is there a public health benefit to taking the medications? And as we think through kind of who should be treated and why, those are the things that I would focus on.
Okay. Good. You've teed up your first question. Go ahead. Take us through the evidence on all four of those things briefly. And because I exactly right. I mean, that you're sort of weighing all those things. The headline was a 90% decrease in the probability of getting super sick. But as you say, in unvaccinated people, so we don't know what that number is in vaccinated people. Do we know anything about decreasing the probability of long COVID, how infectious you are and how long you're infectious for? Those are all very important considerations as you think about taking this drug. And right now, I think we're talking about Paxlovid. We'll switch to some of the other drugs as we go on, but let's just stick with that for the second.
So for Paxlovid, the studies were very clear that for high-risk individuals who are not vaccinated earlier in the pandemic with some different variants, the risk of hospitalization and death was decreased very significantly. So number needed to treat kind of in the high teens range for that population. So for that piece, very clear benefit. As far as decreasing long COVID, we really don't have rigorous data to tell us one way or the other for that piece. For the public health piece, we have kind of a biomarker data. So we know that it decreases viral load a little bit faster than taking a placebo medication. So one would reason that might lead to less transmission. But the studies showing that there is less transmission, for example, in households that get randomized to receive, the person receiving Paxlovid versus not. I have not seen those done or other studies to show that.
Mm-hmm.
And then I think the data on symptom improvement is less strong and, not compelling enough for that to be the only reason to take this medication.
Is there even evidence that, you think that's an easy study to do on your, doing your daily antigen nose swab? Do you turn negative sooner if you're on Paxlovid than if you don't?
The studies did look at viral loads. I don't think that they looked at antigen testing per se, but I think they tested at multiple time points and were able to quantify virus. So a more quantitative measure than the antigen. And
so it'd be reasonable to believe that you're less infectious or stop being infectious sooner, but there is no strong evidence that that is absolutely true.
I think one can hope, but I think there's a lot that goes into whether someone's infectious that is just beyond the viral load. I mean, we have these kind of super spreader and whatnot may be in part due to viral load, but there are other factors that may also play a role.
Right. Annie, do you want to add anything to that?
Yeah, just to say that the viral load, I think, is going to be well correlated with your binax there, and that we're always going to be. I mean, I think when we're academic purists, right, we're always going to be behind in this field. We're never going to have the current variant, and we're never going to have the current vaccine status. So I think we have to let go a little bit of our desire to have the data that will inform us right today on what we're going to do. So we have to extrapolate, and we're extrapolating with Paxlovid now, and it sort of stands to reason, but we don't have the data that we would want about a vaccinated person in the Omicron wave. We're just not going to have that data.
Yeah.
Yeah.
And it's sort of in the theme of extrapolation, as I was saying to Paul, my main fear today, and the reason I still don't want to get COVID is long COVID, both symptomatic and at risk of all these other bad things. Is it also logical to believe that if I got on Paxlovid the day I started having symptoms, that the probability of that would go down? That has something to do with what we've come to learn about the pathogenesis of long COVID. But how do you put that together?
Yeah. I mean, I think it all depends on what causes long COVID, and that's an area of much active debate. If it's all initial immune damage from the high virally driven damage, then that would stand to reason. Right. And I think that we've shown with other diseases like HIV that there's a real benefit of getting the viral load down early in terms of long-term consequences in diseases where we don't clear the virus entirely. So it's certainly, I'm an HIV doctor. I want that virus to go away, and it makes good sense. It may be, though, that a component of long COVID has to do with inflammation that gets set up with the virus being long gone. That's a real active debate right now, as you know. And if that's the case, maybe it helps to get rid of the virus early, but it might be that some damage has already been sustained. But it's hard to argue against wanting to treat people early, with the exception that there's sort of this intriguing phenomenon, which probably gets to the rebound question that I'm sure is going to come up, that if you treat people so early, maybe you didn't give them a chance for their immune system to kick in. And part of what we need to control this virus is, your own natural immune system, much in the way that if we treat people very, very early for HIV disease, they may not develop an HIV antibody. Those HIV antibodies aren't functional and important, but it is a marker that you have driven down the viral load so quickly. So it may be that we are missing a component of the immune system by treating people so early. So just a lot more to learn there, and we can hypothesize both ways.
Okay, so let's switch to the rebound question. That seems to be the hottest question of the last few weeks.
Yeah.
Didn't come up in the early trials, at least that I heard, and then hearing more and more about it. I don't know whether it's being overblown because it's different and new, or it actually is actually fairly common.
Yeah.
What is it, and what is the data on it? And you've already given at least one theory why it might happen, but talk us through it a little bit.
Yeah, so what this is about is it's become clear there's been case reports of people, taking 5 days of Paxlovid, which is what it's approved for, and then somewhere in the next week they stop. People feel better, maybe they have binax, they're negative, and then these symptoms come back within that next week. And people have reported, going from being Binax negative to being Binax positive with symptoms. So it certainly looks like a rebound phenomenon. We've had case reports where they've PCR'd them and showed that. And so it clearly is out there. Is this new? If you go back to the original 100+ page FDA report submission on Paxlovid, they do have a nice chart there showing that, 10 to 14 days in, this did happen in both people who were receiving Paxlovid as well as people who were in the placebo arm. And I think the numbers that were quoted by Pfizer were, very low, 2% in one and 1.5% in the other. So this occurs. It was described in the FDA submission, although I don't think people really paid a whole lot of attention to it. Much of this may have been asymptomatic. The FDA commissioner came out yesterday, or the person in charge of the infectious diseases piece came out yesterday to say, look, much of this was asymptomatic, so we don't know what to make of it. So I think that it's clear that it occurs. We don't know how many people this occurs in. And the things that we're initially worried about would be, well, one, is this drug resistance? Boy, did we just give an ineffective drug, or we gave it for too short a period of time? We've seen this with some of the flu drugs. We're just giving them once, and when people rebound, they have drug resistance. No, it does not appear to be the case that, when these have been sequenced, that these were highly drug resistant variants. Are these people infectious? Well, it would stand to reason that they probably are. If someone is Binaxing, that's a sign that they have a pretty reasonable viral load. And someone who's symptomatic with the Binax, as you said before, I wouldn't want them coughing on me or being in a small space. It stands to reason that they're probably infectious and should be treated that way. Why is this happening? Well, is it that the course of Paxlovid, 5 days, maybe that was just too short? Maybe we should give a longer course. Maybe if we're treating people really early in disease, which seems like a really good thing to do, we haven't given them a chance for their immune system to really get a hold here. I think that that's going to need to shake out. And I think we really need to understand what the prevalence is here, because we're giving out lots and lots of Paxlovid, and right now we're still in the case report mode of it's happening. This is a phenomenon, but not clear if this is just, a fascinoma or really something that we're going to have to contend with.
Does it change your thinking? And I'll ask Sarah the same question. Does it change your thinking about who should get it and not get it, or it's still rare enough and it doesn't sound like the outcome, at least as far as we know, is all that terrible?
Yeah, I don't think that we've seen, it's a really good point. Are we causing harm here? So if you were on the bubble about prescribing this to somebody where you're saying, well, gosh, I don't really think you're going to end up in the hospital, but you meet criteria, I want to prescribe it. Would I not prescribe because now I'm worried that someone might have rebound? No, I don't think that we've convincingly seen that the rebound, at least in the case reports that I've seen, yes, some people can feel lousy, but it's not like, hepatitis B, where if you withdraw treatment, you can have a pretty serious rebound and we're worried. I haven't seen, at least to date, any evidence that besides feeling lousy in some cases, that this is going on. And I just want to point out, you always hear about when people feel poorly. We have no idea we've seen initial small amounts of data from the FDA. Maybe this is happening in a lot of people and we're just not aware of it if they're not Binaxing and they're not symptomatic. The FDA initial data suggests that's not the case, but I think we need to learn more.
This is a complete N of one, but I just heard of a recent case of a rebound who infected other family members on the rebound. So it does feel,
it stands to reason. I would assume
to believe that you are infectious again. So,
right.
But it wouldn't change. It sounds like it wouldn't change your thinking about risks versus benefits overall yet, until we know more.
No, not yet.
Sarah, what's your take on? You're asked to prescribe this all the time and have to work this through. What's your take on this?
Well, the first thing I'll say is, I tend to be a little bit of a skeptic and I want more information. So I think there are some basic questions that we don't know the answer to. So one is the placebo group had 1.5% of people who had rebound. People are not going to tend to go on Twitter and say, I had COVID, I did nothing, and now I feel worse a week later and I Binax positive. How often does this happen in the background? I think that it does happen in people who have natural infections who don't get any intervention. So whether there's a true association, we don't know. And then if there is an association, what the cause is, we're multiple steps away from that, I think. I agree. I think from an infection control perspective, if someone is feeling bad and testing positive and seems like they have a high viral load, I would treat them as infectious. We've seen this all throughout the pandemic in our immunocompromised patients who, some of whom have had really recalcitrant episodic kind of COVID presentations long before there was Paxlovid and we were doing other things.
Okay.
I don't think it would change whether I would prescribe Paxlovid at this point or not, but it may or may not be a phenomenon. I think we need more information.
Okay, let's turn a little bit to Paxlovid in the real world, and you read that list of drug interactions, and it gets pretty scary. And particularly since we're mostly using it in older people, that's a lot of people have something that makes it look like you shouldn't use it, or you've got to do some fancy dancing to get the drug in. How in real life, in your use of it, how hard? I'll stick with Sarah for the moment. How hard has this been to manage the drug interaction piece?
So I think it's a challenge that makes it more complicated than it would be, but it's not insurmountable. So the issue is that Paxlovid both is an inducer and an inhibitor of a common enzyme that helps to break down a lot of medications. So it can kind of both lead to increases in other medications, and other medications can affect it. So it's this kind of like very complicated multi-step thing. And if you look at the list of interactions, it covers every class of medication you can imagine: statins, antihypertensives, psychiatric medications, some of our core immunosuppressant medications. So it is important that whoever's prescribing knows about it and pays attention to it, and is able to get an accurate medication history from the patient, including over-the-counter things like St. John's wort and such. But we have really good tools that can help prescribers. There's the Liverpool Interaction Checker, I think, is probably the best tool that really very clearly just counsels you on what to do if you put in the interactions. So most patients, even if there's an interaction, can get around it with either changing the dose, holding the dose, decreasing the dose, or monitoring. There are a few situations where you really can't get around it, and for that we have alternatives.
Okay. We'll get to the alternatives in a second. So thank you. Maybe one last question on primary use of Paxlovid for treatment. It came from one of our viewers, which is the limitation of the drug to older or at-risk people the right call because of risk versus benefits, or is it a manifestation of supply limitations? And if there was an unlimited amount of supply, would it be reasonable to be giving it to a healthy 30-year-old with COVID? Andy, you want to take that?
Yeah, I mean, I think it gets back to Sarah's question of what are you trying to achieve when you take this drug? So, we've got two very different studies, populations to inform us. We've got the high risk group, was the EPIC-HR study, which is people over 65 or with one or more risk factors. And they said, will this drug help keep you out of the hospital? And the answer was yes, it will help, 90% reduction, keep you out of the hospital. When they looked at people who were younger or didn't have risk factors and asked a different question, will you get better sooner? That study, at least from the interim analyses that we have available, said, no, it didn't yet meet its symptom endpoints. You may not feel better sooner. It did show the viral load came down, and then just numerically, if you compared hospitalizations, which were very, very low, numerically there were less in Paxlovid. But when you're treating a 30-year-old person, you're not treating them to keep them out of the hospital if they're otherwise healthy. I think you're treating them to make them feel better. So, and then for the public health reasons, you don't want them to infect people in their lives, and maybe we could turn things around or infect, there might be a public health benefit there.
Well, and again, the theoretical long COVID thing.
Yeah, exactly, long COVID. Although again, we have no data on that, and I'd like to think that this would be a good thing to do, but I don't really think we can justify that. That's not the reason that in most cases we're treating people. I think it's more rational to try to prevent COVID, period, to not get long COVID than to give Pax. Although we will have these data, it's just going to take a long time to get them because it just takes time down the road. So yeah. I don't think this was restricted. In the beginning it was because we didn't have enough. But let's say we have all the Pax in the world. It is a little bit like the Tamiflu argument. I mean, are we giving? Does it make sense to give this to everyone? And I think at the end of the day, the answer, unless we get more information, is probably no. But the people who really may benefit from it, if we focus there, I think there really is a benefit to trying to keep people out of the hospital. And we hope to get better symptom data to suggest that people do feel better sooner, but we don't really have that yet.
Okay. Great. So if, let's say, Paxlovid is not doable because of drug interactions or some other reason, what is your now go-to second choice in an at-risk person, particularly since the monoclonals, it seems like every week we're learning that the one we're using is no longer useful.
Right.
Do you want to start with that, Annie?
Sure. Well, I'll tell you what the NIH says is that your second choice should be IV remdesivir, which we know works really well, similar, risk reduction in hospitalization, 90%. 3 days of IV therapy. It is hard to get that set up. I know where Sarah practices, they've been able to set that up and, for people at higher risk, and it's terrific if you can get it. But I think in many, many practice settings, that's including my own, that has been challenging. You have two other options then, which include either the monoclonals, which is a single infusion. Right now, all we have is bebtelovimab, which right now looks like it's holding on with the variants. And recent preprint out of Japan suggesting that bebtelovimab looks okay with the multiple different BA variants. But as you say, I think that we've lost a lot of monoclonals along the way, and hard to know. We lack clinical data for bebtelovimab, so there's a lot of unknowns there. But we do still use it, and I think the population we use it in are people who really have trouble with drug-drug interactions with Paxlovid and want a one-and-done treatment where they can, come in and get taken care of. And there is really value to that in some populations and for some people. And then the alternative is molnupiravir, which is also an oral medicine, taken 5 times a day, 4 pills, 5 times a day. And the challenge there is just that the efficacy is lower, somewhere in the 30 to 60% range, depending on which study you look at, for reducing hospitalization and death, which is just a lot less than 90%. But they're basically no drug-drug interactions. So I usually will talk to people if they can't take Paxlovid and try and sort out whether they're a monoclonal type of person, if that's a good fit, versus molnupiravir. And I think there is really a place for both of those. And it would be nice to be able to give IV remdesivir to more people, but I do think there's some challenges there.
Okay. Let me move to 2 other issues. We only have about 5 minutes left. So post-exposure prophylaxis, if someone in a household gets Omicron, actually the most recent data on BA 2 point whatever is that it's about a 40% chance that people in the household are going to get it. How about the idea of giving those other people in the household Paxlovid, assuming there's an indication? What do we know about that? Sarah, do you want to take that? Or Annie, either one. Sarah?
Well, we know based on recent press release data that Paxlovid did not meet the primary endpoint for post-exposure prophylaxis. So the press release, not all that informative, did mention some numerical decrease in risk of infection. It was a 3-arm study, so they randomized to placebo, Paxlovid for 5 days with an additional 5 days of placebo, or Paxlovid for 10 days. And those 2 arms had some numerical decrease in risk of infection, but it did not meet their statistical endpoints. We don't know anything about the confidence intervals or the statistics. It really was just a very brief press release, but doesn't look like that's going to be the answer. I will mention that for high-risk individuals, there is the option of pre-exposure prophylaxis with Evusheld, which is a monoclonal antibody.
All right, so we'll get to Evusheld in a second, but based on that press release at this point, if you had a 75-year-old who was in a household, but not otherwise immunosuppressed, who was in a household with someone who has COVID, let's say they're fully vaccinated, you would not give Paxlovid at this point?
Correct. I would make sure that they have a way to get it if they get infected. And I would have them isolate if possible. But yeah, well, you can't, it's outside of the EUA, but I wouldn't, even if I could.
Got it. Andy, you agree?
Yeah, I agree. And I will say we've all seen the power of isolation. I think many of us personally and many anecdotes of people in the household getting infected, and isolation does work, particularly in vaccinated populations. I think it's not inevitable that everyone in the household, but
yeah, it's a super important point to emphasize. People just often think, somebody got in the household, I've gotten it, there's nothing I can do.
Right.
And the fact is you probably have a 65% chance of not getting it. And if you isolate, probably higher than that. So That's a really important point. So let's end, we only have a couple minutes left. Sarah, take us through how you think about immunocompromised patients these days and how you manage them.
So I think just kind of starting before exposure, making sure that immunocompromised patients are vaccinated to whatever degree we can to get a response. And Dr. Offit, I'm sure has opinions about how many vaccines are needed, but immunocompromised patients tend to need more vaccines. There is an option for Evusheld, which is a preventative monoclonal antibody. Data not hugely strong, but likely to decrease infections in immunocompromised individuals. The study was mainly focused on those with medical comorbidities and not immunocompromised. And then for those who are immunocompromised who do get infections, first-line therapy certainly remains Paxlovid. For those who are on immunosuppression for transplants and other things, they can still get it with close monitoring and discussion and adjustment with their transplant teams. But if they're at high risk for rejection or just had a transplant and there's really concern about that, I would go to remdesivir if possible for treatment. And if that's not possible, I think having a discussion about bebtelovimab versus molnupiravir is appropriate. I think there are a lot of questions about whether we should be giving a monoclonal plus antiviral therapy, and I'm hoping we'll get some more answers about that in upcoming.
At this point, there's no definitive study looking at combination therapy.
Correct. Though, if you look at the EPIC HR study, about 6% of individuals did get monoclonals in that study. It didn't look like there was, it's such a small number, it's hard to tell if there's a difference. But it would be interesting to take a deeper dive in that population.
Okay. Maybe in the last 30 seconds, anything to add to that?
I will just say that Evusheld is really a study in, we're all happy to have it. But I think that, we just saw the New England Journal article come out, and that the people that we have data on are not the people that we're really using it in. So that study was all unvaccinated, less than 5% were immunocompromised. So it's really not the group that we're using it in. And while it was a big relative risk reduction, they reduced the likelihood of getting COVID from 1% down to 0.2%. So I don't think this is meant for, the population that they included in that study, which was really a pretty broad population. I think we're thinking about that exactly as Sarah said, in high risk, immunocompromised patients who are fully vaccinated, but we're worried are still really at high risk. So how to think about it there, but I think this is sort of a study, and the difference between absolute risk reduction and relative risk reduction is really important to keep in mind.
And is there any way through antibody testing or something else to tell whether your vaccines took, and as you make your Evusheld decision?
I think there was enthusiasm for that in the beginning, but I think less and less so now, especially as it's unclear in the Omicron wave. If you're more than 3 months out, you're probably already a little higher risk anyway. So I don't think that the vaccine, that serology is going to be the driver there to determine who gets Evusheld. I think it's more going to be risk. Sarah, do you agree with that?
Yeah, I tend to use serology in people where I'm undecided. I'm not sure their risk is high enough to warrant it. And it might help in decision making. But for the highest risk individuals, I would just go ahead and say Evusheld.
Well, we are over time. We could go for another hour. There's so much going on and so interesting and tough and rapidly changing. So thank you both. Thank you, Paul, as well, for a terrific session. I think I learned a lot. People learned a lot. Thank you all for a terrific presentation. And we'll see you back again in person if you want to in HSW 300 for another non-COVID grand rounds. Thanks so much.